Thank you, Robert, for introducing us in such a lovely way, and for those of you who did the invitations. It's great to be here, Carrie et al. I'm going to start at the top, sort of with young adults, because it's been a long time being in the field of working in anxiety disorders with children and adolescents, and I can't get down on the floor and get up easily anymore. So I moved on to the transition to adulthood, a vulnerable group, as we all know, who are traditionally underserved in mental health care. Partly because going into a child clinic makes them feel very self-conscious and infantilized, and they don't want to be in there, they don't fit. Going into an adult clinic scares them, quite frankly, when they go into an adult mental health clinic. But more to the point, this is the age where they're separating from their parents, or at least trying to, so they're not seeking help because they're not feeling that they should or need to, and parents are often not sure what to do when their kids are at college or what have you. So we're going to talk about this age group, and I don't know how to change the slides. I think I just press. Ooh. And what I'm going to speak about here is how we're using technology to advance what we know and what we've learned about exposure treatment, specifically in the anxiety disorders. Now, first and foremost, as a CBT person, if you treat anxiety and you don't do exposure, you're not treating anxiety. And if you treat anxiety and during exposure, you are not doing the exposure, you're not treating anxiety. So it's very important that exposures are active. Exposures are you engaging the patient to confront what it is they're afraid of. And we used to think that you had to habituate, but actually a lot is about tolerating what is unpleasant, because there's a lot of things we can't habituate to. I mean, turn on the news cycle every day. We're not habituating to, at least some of us aren't. Anyhow, but here we are. I digress, and I won't go into that anymore. Maybe. So anyhow, a big thing about exposure, and when I have people coming into me, and my colleagues, Matt Knock and others around here who do CBT, can tell you when you hear someone has failed CBT, or they say, I've tried CBT, it doesn't work, when you really work with the patient to find out what was the CBT they got, you learn that either exposure was not done. I actually had someone say to me, yeah, well, you know, my therapist gave me Lee Baer's book, Stop Obsessing, or whatever the name of it was, and said, go do this. If I could have done it myself like that, I wouldn't have come to that therapist. And that's a lot of time what you get is the therapist saying, you should go home, and you should try to call that friend and talk to them. Well, you know, it doesn't work that way. That's exactly what has held that person down. That's where the anxiety has been for them. So exposure really has to be valid. It has to be you helping them to confront what it is that they need to get involved with. Traditionally, we do this through role plays. Now, I'm working with young adults, and I used to work with adolescents. But think about this. I'm working with young adults, and imagine a young adult who is afraid and anxious, really overwhelmed about asking someone they're attracted to go out on a date. Now imagine me saying to an 18, 19-year-old, let's pretend that you want to ask me out. Besides being creepy and making me eligible to run for public office, what happens there is it's not real, and the patient knows that it's not real. The patient can then use what we call an experiential avoidance technique of, this is fake, so I'll do it, but it really doesn't do what it's supposed to do then as a therapeutic strategy. So this is really important, is that we have to, you know, figure out ways, how can we make this better, you know, in a way that's more credible. You know, the imaginal stuff doesn't work, and again, if you come to New York City, you need treatment for snake phobia. Don't think I'm going to rub a rubber snake in your face or anything. No, we're going to use Manny, Mo, and Ethel, the 3 snakes. They are real live boas and such. We use real snakes. You have to do that. The other thing that we've learned about exposure is that neurobiological research tells us, and especially in the adolescent years, that it takes real context. Where that person was conditioned or was learning to be afraid, we've got to recreate those situations. The environment has to be credible. Okay? And this is why, with PTSD, Virtually Better is one of the companies that got out of the box with exposure therapy, did so well because they created environments including all kinds of stimuli that actually felt real. And then we also can overcome lots of logistical barriers, you know, that happen if we can use and leverage technology. So what happened is I had no money. But I did have these two technology guys from England who contacted me and said, hey, we're interested in social anxiety. And one of them, Angus Antley, had worked with VR. He's a programmer at Oxford University, did VR for psychosis. But he and Langley, his colleague, decided, what was really important to them, because they had friends and colleagues that they knew with lots of social anxiety, and especially during their college years, they wanted to try and tackle social anxiety in young adults, and they saw the work that we had just been doing anyway, and said, would you want to partner? And we did this by having Lang sleep on the couch at our clinic for a year, because, again, we had no money, and we developed these exposure environments, and I'm going to show you what we did. We came up with, by using some focus groups, and by just having the different medical students, psychology students and such that we worked with, help us to shape what are the things that, in an environment happens in a dorm room, in a cafeteria, in a classroom, and so forth, but also by looking at going back over the fear and avoidance hierarchies of our young adult patients to see what were the situations and activities that were most challenging to them. We came up with 3 scenarios: the dorm room, the classroom with a professor's office, and the virtual party. And we came up with a bunch of different scenarios within these. What I'm going to show you now, and I want you to pay attention to something, this is what's unique about this VR, which we like. You're going to see this young woman go through the tell your roommate to clean up the room scenario. Now, the thing about it is, on the left, or on the far side of the screen, you're seeing what the clinician sees on the computer, and those little boxes are the different things that we can make the avatar do and say. So we can react to whatever the young adult gives to us. So if we could play this, please. Is it you guys who do it, or is it me who does it? Here.
Hi, Ruth here. Welcome back to the control room. Hope you've been well since we last met. Today, we're going to your dorm room where you've recently been having problems with your roommate. Specifically, your roommate has been really messy, leaving clothes, dirty dishes and uneaten food everywhere. Your task is to bring up these problems with your roommate and try to resolve them. We'll now be transporting you to your dorm room. Good luck.
A little Mission Impossible-like. And she's looking around, and you see what she's looking at.
Hi, Ruth here. Try starting the conversation with your roommate about the mess in the room.
Hi. So it's kind of messy. It's a bit messy.
Can it wait? I have to finish this thing off, and I'm about to head out.
Yeah, it's just the room is there's just like a lot of stuff.
I don't understand. What's the problem?
Mostly just like the clothes and the pizza box.
Dude, this is college. This is totally normal. Have you gone and visited other dorms?
Not really.
It's just a few clothes and some pizza boxes. Why is this bugging you so much?
It's not bugging me. It's just it's not clean.
You're not hearing me. Look, just chill. This is no big deal.
I mean, to me I want like the room a little bit cleaner.
You're not exactly perfect either. Well, there's lots of things you do that annoy me, but you don't see me complaining about it.
Yeah, I'm not the best, but there's just your stuff's kind of everywhere.
Look, this is just what sharing with a roommate is like. Get used to it.
Maybe I should get used to it. It's just if it can be a little bit cleaner, that'd be helpful.
Fine. I'll clean it tonight.
So, as you can see, I mean, the roommate gave in here. But what we could do is we actually could make it harder. We could go easier. It depends on where the person is coming in, if, we're easing them into situations or whatever. We do have, how many of you know what sexiling is? Oh, look it. Some of you didn't have fun in college. So essentially, sexiling is when you're not allowed in your room at night because your roommate has locked the door and has someone in there. So we have that, because that was one of the #1 situations that our kids who had flamed out of college because of anxiety had to deal with that they couldn't manage. We also have going and asking the professor for an extension. That came from my own college career, where the professor said, grow up, you're an adult now. That's what the professor says. So there's all different ways that we get them involved in situations that are real to the college student. So what we did just first is we just saw, is this feasible? Is it acceptable? Can we actually do this and get anxiety from these kids who are doing the VR? And so anyhow, one of the things that we did is we put the party scenario, messy roommate, and the speech as a behavioral test for young adults who were just coming in. And also we had an in vivo conversation with someone who was 22 to 24 years of age, around the same age as the clients. So again, to make a credible in vivo conversation compared with the VR. And we find that we get very similar anxiety ratings. And then in fact, the other thing that we found is looking at diagnostic status, that the youth with social anxiety disorder did have significantly higher rates of anxiety, self-reported anxiety in this situation than did those who didn't have social. And we have other kinds of scenarios for prompting GAD and so forth. I just want to sum up real fast. We'll talk later. But now we're at the point where, again, this time with donor money, we're just about to start soon. And Helen, please refer to us, these kids, and anyone in New York City. We're going to do a comparison of CBT plus VR versus CBT plus exposure as usual, with role playing versus a wait list. And then, the big thing for us here is what we're hoping to do, not just is to be able to extend what clinicians can do and give them tools in their practices, but think about this being in college mental health centers. Think about it being something you could do as self-help, even check in, just go to the library and use it for some self-care. And then also for college prep. We're doing this with the high school juniors and seniors who have anxiety so that they can get ready for what they're going to have to deal with. And I'm using it with their parents, because you're Harvard. I have many of our parents send their kids here to Harvard, and they call your deans when you are mean to these kids. And so it's about the kid being able to go up to you and say, I didn't like that, or I need I need something exchanged, or what have you. So anyway, all different ways we'll use this. Thanks.